Yes,
sir.
Yes, perfect. Yeah, Ankit has joined in. And then it's
yeah,
Shrenik
live, sir.
also, he would, yeah.
Yeah,
Ar-
good evening. Over to you, Dr. Ankit and Dr. Fayaz Mehman.
Uh, Good evening, everybody, to this WIROC knee conference. So we'll be starting. I'll be giving it over to the convener of this course, Dr. Fayaz Menon, sir. Sir.
Uh, Good evening, everyone. I am Dr. Fayaz Memon, and I welcome all of you on behalf of Bombay Orthopedic Society for this pre-conference webinar on knee arthroscopy. As we know, we have named it as knee dip, mastering the fundamentals of knee arthroscopy. And I would like to invite our first speaker, Dr. Nikhil Agrawal. Agarwal, right? Yeah, Dr. Nikhil Agarwal. You can share your screen, and over to you. I would request all the speakers to please abide by the time. You got 12 minutes of time, 10 plus 2, but you can utilize all 12 of them if you want to. Please do not offshoot the time, because otherwise it will be tough for us to manage it within the given time. Over to you, Dr. Nikhil.
Yeah, good evening, everyone. I hope I'm audible as well as my screen is visible to you all.
Yes.
Yeah, so I'm thankful to Bombay Orthopedic Society. Thank you, Fayaz, and thank you, Ankit, for hosting me today. My topic for today is on diagnostic knee arthroscopy. Few words about myself. I'm from Wokhad, Mira Road, and also attached to Jagjivan Ram Railway Hospital. So we'll start with paying some respect to the father of modern arthroscopy, that is Masaki Watanabe, who first started the arthroscope, and as you can see on the right side of the screen, and used to diagnose conditions with help of the naked eye and very few instruments which were then available in the 60s era. However, we have proceeded towards now the modern arthroscopy with all the modern gadgets. And today the purpose of doing diagnostic arthroscopy just for diagnosis is seldomly done. So mostly it is combined with the therapeutic procedure. It's a prerequisite before all the therapeutic procedure to undergo a diagnostic round and identify pathologies which are often missed on MRI. Also, the diagnostic scopy helps in assessing the extent and the severity of the in a lesion which we are assessing with help of a tactile probing too. So starting with, let's understand the setup and the position. There are two types of position for the knee arthroscopy. That is the leg hanging position with the help of a leg holder at the thigh. And one is with the knee on the leg on the table position. All the diagnostic scopy before that, you always examine the knee under anesthesia to have an assessment of the preoperative ligament laxity and other issues. So the key to a successful arthroscopy is getting the portals right. And for the diagnostic arthroscopy, there are a few portals which one should know. The standard ones are the superolateral, superomedial, anterolateral, anteromedial, and the posteromedial and the posterolateral portals. So let us try to understand the portals and how to make them and how the diagnostic scopy becomes simple. So for the beginners, I would suggest these are the four common standard portals which are oftenly used for diagnosis. That is the anterolateral and the anteromedial. And very often you will require to do the posteromedial and the superolateral portals. The optional portals, we have the superomedial portal, the posterolateral portal, the transpatellar tendon portal, and the transseptal portal. However, these are less commonly used for certain specific conditions. At that time, these portals are useful. So this is the standard anterolateral portal, the workhorse of the diagnostic arthroscopy. That is also known as the soft spot portal. It is located 1 centimeter above and 1 centimeter lateral to the patellar tendon. And you note that surface marking, I would advise for the beginners to do the right way of doing the surface marking is to mark all the anatomical landmarks, and then go ahead with your anterolateral portal, which is a centimeter lateral to the patellar tendon. That is how you do the start with your diagnostic scopy. Be careful that the portal is not very close to the joint line. You can lacerate the lateral meniscus. Neither it is too superior to the joint line. You can damage the condyle. and neither it is too closer to the patellar tendon, you can land up in the fat pad, and then the visualization and the maneuvering of the scope becomes difficult. The anteromedial portal is often the outside in technique, where you visualize from inside. It's an inside out technique, sorry, where you visualize with your scope inside the anteromedial compartment, and then with the help of a spinal needle, you find out the location just above the meniscus and pointing towards the pathology which you want to address to. This is also a centimeter above the joint line and the 1 centimeter medial to the patellar tendon, and it is the most common working portal. So very important is to have a systematic diagnostic round before you undergo any other ACL reconstruction or any other therapeutic procedure. The systematic round involves the first put your scoping in the suprapatellar pouch, see the patellofemoral joint, that's the patella and the trochlea, examine the medial compartment, the middle meniscus and the cartilage, then go to the notch and see the ACL and the PCL, come to the lateral side and see the popliteus and the lateral meniscus, and also at times you have to enter the posterior middle compartment. So this is how your diagnostic scopy looks once you enter the joint. That's the patellofemoral joint, patella upwards and the trochlea down. Enter the suprapatellar pouch. Go on the lateral side, examine the lateral gutter. Appreciate the synovial folds which are seen on the lateral gutter. These are the synovial folds which are normal in structure. That's the suprapatellar pouch. Coming on the middle side, that's the middle gutter. You will often find the loose bodies over here. Then coming on the middle side, examine the meniscus. That's the middle meniscus. It's very important to probe the meniscus upwards as well as from the underside of the meniscus. That's the meniscocapsule junction. Look out for any tears over there. The probe is your extension of your finger, and it's very important during diagnostic scopy to feel the meniscal, feel for the structures, and identify any hidden tears underneath the meniscus. Also look for the cartilage condition on the middle side. Then come to the notch side. This is the healthy ACL, how it looks. Again, with your help of a probe, you assess the tension on the ACL. Many times you will see the ACL is stretched out in partial tears. Many times you diagnose a single bundle tear with help of probing. That's the PCL over there next to the ACL. And that is the lateral compartment you enter, assess for the cartilage with help of your probe and the meniscus. The entire meniscus, right from the middle to the posterior part and the root. So this is how you take a diagnostic arthroscopic round. And with help of the standard anterolateral and the anteromedial portal, basically all the basic knee procedures can be performed. That is your meniscus pathologies, the ACL reconstruction, synovial issues in the suprapatellar pouch and the middle gutters. Any loose body which is commonly seen in the gutters can be done with these two portals, and the cartilage procedure like microfracture. This is how the usage of a superolateral portal often comes into picture when you want to assess the patella and the trochlea specifically. This is a 2 centimeter proximal and proximal lateral to the superolateral border of your patella. It is done with the knee in full extension, and mostly for assessing the patellofemoral joint articulation and tracking is a very useful portal. I often use it. This is how you do it with the knee in extension. You see for the mark the superolateral border of your patella. Note the patella position changes in the flexion and extension, and then coming just superlateral to the patella around 2 centimeter, enter into the knee joint. So this is the patella. We are going from the superlateral portal, and we can exchange your telescope and insert a telescope in the superlateral portal and appreciate the patella and the trochlea very nicely from the superopatellar case. That's the patella moving from the superolateral portal, and assess this is a case of a lateral instability of patella. And from the superolateral portal, you appreciate the cartilage damage as well as the lateral instability of the patella very nicely. So again, an example, putting the scope in the superolateral portal and with the probe from the anterolateral portal, you view the trochlea and the patella. And very nicely, you can appreciate and identify the extent of the chondral damage in this particular case of the patella. So very useful portal and very commonly used for patellofemoral problems. This is an example how a diagnostic scopy is useful in case of an ACL tear, and that's a drive-through sign of when we're entering the probe on the middle compartment, how easily the probe can enter the middle compartment. You can easily see in this particular video. And that's a sign of the superficial MCL tear or MCL insufficiency. And this particular probing, especially in case of ACL and MCL tear, is very useful. This sign, this is known as a drive-through sign. Posterior middle portal now very commonly also used in case of ACL tears to identify the ramp lesions and to treat them. So it's very important to know how to make this portal. It is done in 90-degree flexion and the soft spot between the MCL, middle head of gastroc, and the semimembranosus. And it's very commonly useful for the PCL reconstruction, any synovial pathology in the posterior compartment and the ramp tears. So that is the needle which is coming in the posterior middle compartment, and that's how you make your posterior middle portal. There are also the other portals, that's the posterolateral portal and the transseptal portal, which are less commonly used. So with help of this posterior middle portal and with the instrumentation in the posterior middle compartment and viewing from the anterolateral area, you will identify the unidentified ramp tears, and you can assess the stability of the ramp tear. And also lateral posterior root tears are often missed in MRI, and these two particular lesions are very commonly diagnosed only after doing a diagnostic round, which my further speakers are going to speak. Certain important structures which you will often encounter when you're doing a diagnostic round, especially if you're doing a chronic ACL tears, are these cartilage sort of lesions, which you will often come across. And you can also, it's very important that you deal along with, you identify them and deal accordingly. This is a microfracture case in case of a chondral defect. This is another case where you are doing an ACL reconstruction chronic situations, and you see a lot of fibrillation of the cartilage. And then you go ahead and do an abrasion chondroplasty in this particular fashion. Diagnostic tool in case of a patellar dislocation and helps in identifying a diagnostic round, helps in locating the loose body. And this is my probe in the superolateral portal I'm viewing from the anterior side, and helps me in locating and finding the loose body which is in the lateral gutter. Another case of a 42 female with a knee pain and a localized swelling in the knee joint, complaining of locking and pain, and a diagnostic scopy will help you in localizing the lesion, identifying the extent of the tear, as well as treating this lesion. This is a case of a localized form of a pigmented villonodular synovitis. This is another case of a young female with a knee pain and swelling, often recurrent effusions with recurrent aspirations being done. MRI shows a chronic synovitis in a less commonly etiology, and hence it often goes underdiagnosed in certain centers. And hence in this particular situation, diagnostic arthroscopic round helps us in diagnosing as well as treating this pathology. This is a diffuse type of a PVNS. You can appreciate the synovitis. Another case in a 38 female with chronic effusion, chronic pain. MRI is not very conclusive at times. And in this particular case, you can see a synovial plica and multiple loose bodies, which are the cause of a knee pain. And a diagnostic round really helps in making a established diagnosis as well as treating this particular etiology. And you can appreciate the multiple raised bodies, which can be removed by shaver and then can be sent for histopathology. Multiple times you can also encounter such situation, which is the crystal arthropathy, especially in uric acid gout cases. And while doing ACL reconstruction, at times you often see this cartilage being involved in this particular manner, and then you can obviously inform the patient regarding the prognosis of this particular condition and this particular case, and the diagnostic scopy thus becomes very important. So to summarize, a quick diagnostic scopy in a systematic manner is a must in today's era, before every procedure, which I would like to emphasize in today's talk of mine. Thank you so much.
Super.
Excellent talk as usual, Dr. Nikhil. I invite our second speaker, Dr. Nilesh Vishwakarma. He's been very busy. In fact, he's traveling maybe day after tomorrow, but still he has agreed to give a talk today. So over to you, Dr. Nilesh Vishwakarma. He'll be speaking on graft options in knee arthroscopy.
Yeah. Sir, is my screen visible to everybody?
Yeah.
Yeah. Sir, first of all, thank you so much, yourself, Fayaz sir, and Ankit, and a very good evening to all the colleagues out here. So the topic is a brief overview of the graft options that we have in the ligament reconstructions with us. And I'll be just touching upon the common things that we tend to use during our surgical interventions. So let's go ahead, dive in. Yes, we are definitely spoiled for choices because we do not use only one particular kind of graft. We have a lot of choices to depend upon, but we have to understand that the graft choice is an adjustable extrinsic factor that is there in our hand, and we should always be mindful and adopt it in a right way. So we should always try to see that it is not one size that will fit all. So we have to modify depending upon the circumstances. I'm going to divide this particular talk depending upon these particular outlines. So what is the graph that we are going to use? Who gets it? When do they get it? Why do they get it? And how do they get it? So we'll just try to touch upon all the aspects of that particular graph. So let's dive into the quadriceps graft. It's slowly and gradually the popularity is increasing. It's a very good graft that many of the guys are now switching on to. And let's go to who gets it. Basically, the quadriceps graft, the young patients, basically who are skeletally immature. So there is no violation of the patellar tuberosity, the patella immature patellar physis or the tibial tuberosity or the physis. When do they get it? Whenever the person is involved in a high demand sports or a high level pivoting sports, especially if you find a patient who is hyperlax. So we do consider the quadriceps tendon. And people who require kneeling action, so it's a very good option to depend upon. So why do we consider that? So we all know that yes, there's a very low graft rupture rate of the quadriceps tendon. There is 20% of more collagen as compared to the bone patella bone, and it has got the largest cross-sectional area, almost 62 millimeters square. So it's a thick, robust graft. There's a very low donor site morbidity, almost lowest among all the four that we are going to consider. So it's a versatile graft. We can go ahead with a full thickness graft or a partial thickness graft depending upon the situation. So let's go on to the final point. How do we take it? So there are traditional open methods that are there, and there are minimally invasive techniques also that are available to harvest the quadriceps tendon. After the surface marking, we go ahead, we cut the particular, after the skin incision, we encounter the fat. We can choose to excise the fat if it is coming in between, if we are going in a minimally invasive way, or if we are opening it formally, then there is no need. The upper part of the patella has to be identified, and that is where your the end of the graft is supposed to be there, and then you can take about 7 centimeters proximal to that particular level. So you can use a needle to identify the upper pore of the patella, and then you can mark the tendon, and then you can harvest it depending. It's a very simple, straightforward technique. You can do the stitching part first, or you can actually hold it with the cockers or a forceps, and then you can cut it upon. So it's a very straightforward technique, open technique, preferred by many of the new surgeons as well. Few things that we have to be mindful about this particular quadriceps tendon is that there is a, because it's layered, so there's a consistent fatty streak that is present. We have to be very, very careful not to go significantly laterally. Otherwise, we are going to go into the muscle mass. The best is to be within 2 millimeters along the border of the vastus medialis obliquus. So as we know that there are three layers that we can actually see onto this particular. The upper one is the rectus, the under one is the vastus intermedius. But in between, you have the vastus intermedius, superficial, and the deep part. And there is a tensor of the vastus lateralis that also forms a part of it. So as you go from superficial to deep, you have to be aware of this particular configuration of the quadriceps tendon. Significant issues can develop if you are not able to close this particular defect properly. Hematoma formation is one particular thing. If you are not cross-checking it during the harvesting, you can actually rupture the cap. You can go ahead and incise the capsule. In that situation, the hematoma that is going to form will seep into the surrounding tissues, and your rehab will get compromised certainly. So try to see that how you can avoid this particular complication by going ahead with a water type suturing. It's a graft that tends to be oversized. So depending upon what size you want, you have to be very, very specific. And generally after the stitching, you see that the graft tends to become one size bigger. So you have to be mindful about this. And this is one particular graft that doesn't behave properly with respect to entromer. So if you've got a short heighted person, you can still have a graft which is a very good length graft when it comes to quadriceps. So let's go on to the second one. A long fleshy graft, which is our peroneus longus. Again, quite easy to harvest. Who gets it? Young and old alike. Again, people who require kneeling action, people who have got valgoid knees, and people who have this medial sided injuries. So you have to understand that you will not try to go ahead and do the hamstring harvest in this because the medial side is already compromised. Again, it's a bone in the multiligamentous situations. It's a versatile graft. Again, you can go ahead with a 2-strand, you can go ahead with a 3-strand as well. The diameter and length are never a problem when it comes to peroneus. 8 mm peroneus longus will have definitely a good amount of failure road and a stiffness as compared to the 10 mm bone patella bone. And again, it is comparable to the quadriceps. Double is comparable to the quadruple hamstring. So that is how it is. And we can definitely avoid the anterior knee pain significantly in such kind of situations. It can definitely be erroneous. One has to be very, very aware of the certain structures that are there. Very importantly, we have to beware of the peroneal nerve and also the sural nerve at this particular location. And the 4 to 5 centimeter is the upper limit of the tendon stripper that is going to go. So because of the peroneal nerve. You have to identify the two tendons, which is the peroneus longus and the peroneus brevis. The feature which actually distinguishes it is the brevis has got a low-lying muscle belly. But in literature, there are certain instances wherein you find that even the peroneus longus has got a low muscle belly, but very rare. So identification is a must before you go ahead and strip it. Once you have identified it, there are two ways. Either you cut the peroneus longus, suture it, and get the upper part of the tendon through, or you suture both the tendons. The bye has to be sutured, the brevis has to be sutured to the longus so that the distal function is not compromised. And you have to understand that here in this particular situation, you have to use a closed tendon stripper. Never ever go ahead with an open tendon stripper as seen in this video, although, because if you lose the track of the peroneus longus above in the mid leg or above, then it can be disastrous. We try to avoid this particular tendon in specific population, which are basically going to use this action. So there are instances wherein you can develop a first rib plantar flexion issues or a reduced peak ankle eversion as well. Anton was the one who demonstrated that there is almost 8.4% varus sterile tilt incidence that can develop after the peroneus longus harvesting. So let's go ahead with the third, which is our favorite as well. It's a gold standard that we know already, and it is still the gold standard, which is the bone patella bone tendon. Who gets it? Yes, younger patients, definitely. Patients who are hyperlax, so we want a stiffer graft. We do not want to go ahead with a hamstring in such kind of patients because of poor genetic collagen as well, and high demand players as well. Okay. Again, we have to consider this significantly because there is a very high load to failure. There's a faster incorporation of the graft. So there are many soccer players, many footballers who want to actually go ahead with this so that they can get back to the football in a matter of 3 to 4 months time. So although we do not advise them, but then there are instances wherein because the bone to bone healing is faster, they do opt for it. Aggressive rehab can be started because of the early healing rates. So as we already have we can see that there is early return to the sports. Now, whenever we take this patella tendon, the flexor strength is never a problem. It is the extensor strength that is a problem. So flexor strength, which is needed, explosive as well as long static, is never a problem whenever we take a patella tendon. How do we take it? Again, there are traditional ways. You can go ahead, do the marking, incise fully. Important thing to see here is that you have to preserve the paratendon. It's a distinct structure. We have to identify it, and whenever we have harvested the graft, we have to close that paratendon so the hematoma formation is restricted and the function is not significantly compromised. You can go ahead to take a bone from the plug. 10 mm to 20 mm is the plug that you can take from the patella as well as from the tibial tuberosity. You can take a straight incision. You can go ahead with a mini incision, cross incisions, and multiple patterns can be created in such kind of. Okay, so let's go out with the final which is the hamstrings. Again, it's the most preferred graft. It's workhorse for majority of the arthroscopic surgeons out here. ACL, MCL, MPFL, multiple other utilizations can be, this can be utilized for that. Who gets it? People who are involved in not high pivoting sports, but moderate sports activity level. People who are not going to participate at high end, who are domestic kind of an injuries who sustain. So, and additionally, hamstrings are also preferred if the patient is a skeletally immature patient. Uh, we we do not want to use hamstrings very specifically in patients who require kneeling action. So that also has to be avoided to a certain extent, where there is a very low donor site morbidity. Again, it's a versatile strand. You can go ahead with a triple, you can go ahead with a quadruple. We are not fiddling with the extensor mechanism, so the extensor mechanism compromise is not there, and there is a lower osteoarthritis progression as compared to bone patella bone, as cited in literature that we'll see. So how do we take it? It's a very straightforward procedure: 1 inch medial, 1 inch below the tibial tuberosity, trying to identify the pes, and then importantly taking a cut on the pes and trying to isolate the hamstring tendon. Now here there are 2 to 3 things important. One is this particular slip to the gastrocnemius has to be cut. If you are not able to cut that slip to the gastrocnemius, you will not be able to, you can pre-amputate the graft and then you can land up with a short graft. So this slip to the gastrocnemius has to be cut before you go ahead and harvest the hamstring tendon. Okay. Now, let's go ahead very shortly with respect to certain important parameters that we have to consider when we consider all these 4 things. One is the graft failure rate. Now, when we see the bone patella bone, the graft failure rate is significantly less. When you compare the quadriceps tendon, it becomes almost 5%. 2 to 5% is the range. But when the Tegner activity sports level is significantly higher, the quadriceps also has got a higher graft failure rate. But when it comes to hamstring, it is 11.5. So it is significantly higher when we consider hamstrings. So that is how the graft failure rate is going to vary depending upon the choice. So whenever a high demand, probably we should think twice whether to go ahead with a hamstring tendon in such kind of situations. So as the graft failure rate is higher, patients with hamstrings will have a double higher risk of the revision in such scenarios. Osteoarthritis, yes, it has been reported very specifically with bone patella bone tendon, theoretically also present in quad, but there's no evidence that is there because we are trying to go ahead with the extensor mechanism harvesting. This tendon, bone patella bone, has got a supraphysiological graft. The stiffness is significantly high. And because the stiffness is high, it can result in a constrained knee. So you have to be absolutely anatomical. You cannot have any kind of error. And because it becomes a slightly more constrained knee, you can have an increased chondral stress. And now this is theoretically linked to causing the osteoarthritis. But again, now bone patella bone, you have to avoid in an elderly population very specifically. Peroneus or the hamstring serves good in such kind of situations. Infection risk is significantly high whenever we are trying to go ahead with an hamstring. Now, this is a very significant thing. Hamstring has got the highest risk of infection amongst all. The surgical site infection ranges to 1% on an average. And we, as an arthroscopic surgeon, we can see that the graft choice has got an influence. So if you have a high risk patient who has some sort of risk of infection because of systemic parameters, you have to think that probably it is better to avoid the hamstring tendons in such kind of patients. Tunnel enlargements are one of the reasons, are one of the consequences of using hamstring, but it has not shown any kind of functional deficit, and the knee scores do not correlate with any kind of tunnel dilatation whenever we are trying to use the hamstring tendon. Anterior knee pain and kneeling pain, very specifically the donor site morbidity, we can see that the donor site morbidity and the knee is significantly high in bone patella bone. But having said that, even the hamstrings will have the anterior knee pain and the donor site morbidity, lesser definitely when it comes to quadriceps tendon. Peroneus, definitely we are not going to harvest it from the in and around the knee, so there is no value assigned to it. But bone patella bone, anterior knee pain is a significant problem. Beyond these particular graphs that we are also seeing that there is a surge in some sort of synthetic grafts which are there. So this jewel is something that we have seen in multiple conferences, and people are now trying to probably use it whenever we find ourselves trapped in a multi-ligamentous kind of a situation wherein we do not want to touch the other knee. I do not have any significant experience with the jewel, neither with the allografts. But yes, in future, probably we may see that there are certain allografts which we can use. There is absolutely no donor site morbidity, but we have to be mindful that if we are using the allografts, then the revision rate is significantly higher. And because the rupture rates are higher in allografts, as the remodeling or the immunogenicity can be a problem. So I believe that takes care of the graphs that we tend to use in our practice in general, and that's it.
Thank you
Yes,
very
sir.
much. Thank you very much, Nilesh. Excellent
Yes.
presentation. I now call upon our next speaker, our very own moderator,
Thank you, sir.
Dr. Ankit Marfatia. Please start with the lecture.
So am I audible?
Yes.
Hi, thank you so much for having me. Thank you, WIROC 2024 organizing team. ACL reconstruction. So let's just start off with a case. We've heard about the graft options. We have heard about a diagnostic scopy, but we get a patient in our OPD, 3 weeks back injury, 39-year-old male with a twisting injury while playing cricket, complains of instability. On examination, his anterior jaw is positive, his lachman is positive. These are MRIs. MRIs are suggestive of a complete ACL tear as well as contusion over the lateral femoral as well as tibial condyle, suggestive of a complete tear of the ACL. So the objective of this talk is when to operate the patient, how to go about the ACL reconstructions, what are my graft options, what is the post-op rehab, and what are the future trends that we've already listened to. So I always start off with the patient with pre-rehabilitation. So prehab is one of the most important things in my practice because I feel that if there is a loss of motion, quadriceps are weak, there is instability, then prehab really takes care of this. If there is swelling in the knee, it has to be subsided. Of course, prehab is only done after an MRI, which is ordered very, very early. Because if there is a bucket handle tear of the medial meniscus or there are other concomitant injuries which require early intervention like avulsion fracture or something like that, which are missed out on an X-ray, then that is the only time I don't go for rehab. So there's a paper on ACL prehab which improves post-operative strength and motion and return to sports in athletes. This paper states that there are 2 phases of rehab that you can go for: the 3-week rehab or the 6-week rehab. All the rehab goals are broken down into getting normal range of motion, decreasing swelling and inflammation, increasing strength, and improving basic balancing and proprioception. They have got different protocols that they have had, but these are basically the same exercises that we would go through in a post-operative period with a patient, so as to gain back the quad strength and the range of motion. Prehab is very important to prevent also re-injury and contralateral injuries after ACL reconstruction. Graft options. We have had an excellent lecture by Dr. Nilesh Vishwakarma, who spoke about all the grafts, and these are the current trends that are there of choice of graft. The quadricep graft, the bone patella bone graft, the hamstring graft, allografts, other graft options, even Jewel. So he's mentioned all of them. He's already spoken extensively of the same. So graft options is something that we already know about. Now comes to the steps of surgery. After doing a diagnostic round, we need to find a femoral footprint. Usually in an ACL reconstruction case, there will be some amount of remnant left behind at the femoral footprint. The footprint is located posterior to the lateral intercondylar ridge, and 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 there are multiple ways of classifying where the footprint will be. In arthroscopy, we do not talk about anterior, posterior. We talk about high, low, deep, shallow. So the reason for talking like this as high, low, deep, shallow is because the knee is in 90 degrees of flexion. And in 90 degrees of flexion, the basic lateral intercondylar area becomes, it's in a flex position. And in a flex position, we can then comment on whether the footprint is high, deep, low, or shallow. And on the basis of that, we then decide where our footprint or where our femoral tunnel should be placed. However, if you have a remnant, which can be seen in picture A on top, then we can just basically go in the center of the remnant and then drill the tunnel. If we do not have any remnant left behind, like which is seen in the lower, in a chronic scenario, then we use the lateral bifurcate ridge as well as the lateral intercondylar ridge as reference points, and then mark the center or slightly posterior, or as we say, deep, to that, and then we go in for creating the femoral tunnel. There are ruler methods of finding the footprint, because the ACL footprint is said to be 14 millimeters. So at the 7 millimeter mark, we can pass the femoral tunnel. Once the femoral tunnel has been made, it will look like this. Now for the tibial tunnel, again, using most ACL reconstruction cases, there will be some amount of remnant left behind. It's only in the chronic scenarios that there can be an issue. If there is remnant left behind, then we use using the remnant as a reference point. We drill the tibial tunnel with putting the jig at 55 degrees. And there is a paper by George Kala and Robert Laplace, which states that the center of the ACL for the tibia is just along the root of the lateral meniscus root, anterior horn. It is just ahead of that. And this will also, there were other referencing ways of marking this tibial tunnel, which was 7 millimeters proximal to the PCL in the center of the intercondylar notch, as well as just in line of the lateral meniscus anterior horn. However, using the footprint would be the best and the most ideal way of creating the tibial tunnel. Fixation devices. There are multiple fixation devices available in the market. The ideal fixation device would be anatomic, biocomposite, safe and MRI compatible, and easy in revision scenarios. So there are multiple ways of using a fixation device. There is interference screws, can be metal, PEEK, absorbable. There can be suspensory fixations, which will be cortical buttons or fixed loops as well as adjustable loops. There were also earlier staples and screws and washers used. Sometimes we do use them in certain multi-ligament case scenarios or repair scenarios also. For femoral, cancellous screws also have been an option that have been used, as well as using suture anchors for additional stabilization of the ACL graft. So the types of fixation would be an aperture fixation or a suspensory fixation. Aperture fixation meaning at the joint level, and suspensory fixation means at the cortex. The graft heals best at the aperture because that is where the Sharpie's fibers are growing into the graft and the graft is held on. In any revision scenario, we have noted, at least I have noted, that the graft which is there in the tunnel, that has not been incorporated with the tunnels. It is only the graft which is at the aperture of the tunnels, that is the only one that gets incorporated. The choice of fixation can be dependent on the graft choice as well as the graft choice as well as the number of ligaments that are involved. So and it also depends on the technique in which we are doing the ACL reconstruction. If we are using the standard ACL reconstruction technique of drilling the femoral tunnel and the tibial tunnel, or we're doing all inside ACL reconstruction. Rehab. One of the most important things that a patient with an ACL reconstruction should undergo is proper rehabilitation. Because rehab is the one that helps in minimizing knee pain, swelling, inflammation following the surgical trauma, re-establishes full range of motion and neuromuscular control, enhances the recovery and return to pre-injury physical status or sporting activities. Now, which type of rehab should we go for? There is the accelerated one and there is the usual conventional type of rehab. However, in this paper, it has been stated, and in even my personal practice, it has to be based on a multitude of factors. There has to be objective examination of data, return to sports of functional testing battery, biological tissue healing, psychological readiness, demands of sports, and patient-specific factors such as concomitant injuries and comorbidities. It is patient-specific rehab. We cannot tell a patient that you will be all right in 3 months' time or 6 months' time or 9 months' time. It has to be patient-specific. So let's come back to the case. 39-year-old male with a history of twisting injury while playing cricket, as I've shown you already the MRI, suggestive of a complete ACL tear. And this was the diagnostic arthroscopy, showing a torn ACL stump. The femoral footprint was debrided. As you can see, the fibers are still present. The torn ACL was palpated and a femoral tunnel was made. The tibial tunnel was made trying to preserve the maximum portion of remnant, and the ACL graft was passed below the remnant fibers of the ACL. This helps in proprioception as well as early recovery, and a smaller graft also will be acceptable. There was no impingement during this case, and that has to be checked when you're doing remnant preservation. So we understood prehab, the different graft options. The tunnel placement is of utmost importance because ACL reconstruction failure due to surgeon can happen because of faulty tunnel placements. That is something we can control. Fixation devices are utmost important during the early period of ACL reconstruction. Post-op rehab is of utmost importance. Otherwise, there will be or can be dire problems with the patient. Any questions? Thank you for your patience. That's the post-op X-ray.
Excellent presentation, Dr. Ankit. I now call upon Dr. Shrenik to deliver his talk on meniscus tears, and I'm sure he will leave the roots for me.
So, can you hear me?
Yes, absolutely. But we are unable to see your.
No, just one question. What is his opinion for the ACL repair?
So ACL repairs are done for a very small percentage of patients. The torn ligament that you had seen, even though I mentioned 3 weeks, he did because of my center being a government hospital, he did come on table at 6 weeks. So if you look at the rounding off of the ACL, I would have wanted to take few stitches in the ACL remnant and then repair it with his reconstructed graft. So I would be using the remnant as well as the reconstructed graft. In this case scenario, he came to me at 3 weeks, operated at 6 weeks, and then I felt it was rounded off. So that's why I shaved it off and I just went ahead with the ACL reconstruction.
Okay. Thank you.
Thank you.
So can you see the screen?
No.
1 sec. Right. One second, sir.
An option down there.
Yeah.
You can share your screen.
Now? Now
Yeah,
you
we
can
can
see?
Yes.
Yeah.
Okay. So I'm Dr. Series-7. I'll be speaking on the meniscus injuries. And thank you, WIROC. Thank you, sir, for inviting me for this talk. So this talk will be basically to overview on the anatomy of meniscus, to identify the anatomical structures related to the meniscus. The evaluation will be to recognize the mechanism of injury for the meniscus, understanding the common histories or a common mode of injuries for the diagnostic modality, whether radiological diagnosis, the operative management. So we'll leave some for you, sir, for this, and then non-operative management for the meniscus. So the anatomy, the medial and lateral menisci is basically medial meniscus is C-shaped, surrounded by ACL, PCL, and MCL. Shares the medial fiber with the MCL. Lateral meniscus is more circular, surrounded by PCL, LCL, and is partially by the ACL, and it shares the medial fibers with the ACL. They are located on the top of tibia, covering the femoral and the tibial condyle. Both structures translate into flexion extension of knee, translates with slight rotation in the knee. Basically, the medial meniscus attachments are superficial in relation to ACL, deep in relation to PCL, provides a base for the femoral condyle. Lateral meniscus, basically attachment deep in relation to ACL and deep into relation to PCL in the posterior part. So transverse ligament, basically they anteriorly join the two menisci, the transverse meniscus ligament. 70% of the knee, the lateral meniscus attached to the femur by either a posterior ligament of Wisberg or an anterior ligament of Humphrey, and both usually occurs around 6% of patients. Anatomy, the one thing that you need to know in the meniscal pathology is the discoid meniscus, the primary effect mainly in the lateral meniscus, and they are usually classified into either incomplete, depending upon the tibia, or the complete, or the Wisberg ligament type, where it looks like a normal meniscus, but there is no posterior coronary attachment. So these are usually an arthroscopic finding that you will see. The one thing that we need to know about the meniscal injury is blood supply and the innervation. So blood supply, this is mainly an avascular tissue. It is basically supplied with the blood vessels per month or 30% of the zone, which we called it as a red zone. And the inner zone, which is mainly a white zone, which is usually synovial fluid. It is innervated in the peripheral part, so it's a painful thing. Nociceptors, the free nerve present peripheral parts. And the mechanoreceptors, those are usually Ruffney's or Pacinian or a Golgi tendon apparatus. So the related anatomy in relation to the meniscus are the cruciate, collateral, synovium. Will not go into the anatomical detail per se, but what we need to know is the stresses principle in the meniscus. So weight bearing produces the axial force, but the meniscus is the structure which converts the axial vertical compression forces into the axial surrounding forces or hoop stresses. The axial forces are converted into the tail forces on the circumferential collagen fibers. So it reported 70% of the load in the lateral compartment and almost a 50% load in the medial compartment are translated through the menisci, and a compressive load almost 50% through the posterior horn in the extension and 85% transmission of that 90 flexion menisci. So the evaluation of meniscal injury is meniscus injury mechanism, tear pattern history, and diagnostic modalities. So mechanism of injury is usually internal or external rotation of the knee upon the flexed knee during the bearing, or without ligament injury can happen. Can be an excessive force on a healthy meniscus or a normal force on a degenerate meniscus. That depends on the patient, age of patient. So the most important thing as far as the treatment is concerned is to recognize the tear pattern and differentiating in the different tear patterns. So meniscus tear are usually basically in two categories. They are either acute or post-acute tears, chronic or degenerative tears. So acute tears are commonly result of physical activity. Males are more common as they are more into a sport category. Women are present with more of peripheral injuries, have a specific pattern, either a horizontal, vertical, real, or complex. They are operated with surgery, meniscal repair, meniscectomy, meniscal allograft, followed by a physiotherapy. Chronic or degenerative meniscus common injured above 55 years of age. They requires minimal stresses and can be managed either with conservative or a surgical intervention. So just to touch upon a couple of meniscal tear patterns, these are vertical, longitudinal, or a bucket handle tear. It goes either along the anterior to posterior of the meniscus along the circumferential fibers. Bucket handle tears run nearly almost the entire length of meniscus of flap impinges into the intercondylar notch, resulting into the locking, and these patients usually present little early. Flap oblique or a paratic tear. These are common tears, occurs in the posterior middle third meniscus. So the radial or a transverse injuries or a tear. So they begin inner free margin and the capsule. Typically occurs in the same area as that of flap tears. They can progress with the activity and they may result in the complete loss of meniscus function, hook tension if they reaches to the periphery. That gives like a complete meniscectomy type picture. So horizontal usually in older individual begin in the inner free margin and move peripherally. They usually divide the meniscus into the superior and inferior flap. Either of this may be unstable. This gives like a fish mouth type appearance. And the combination of everything is like a complex tears. Those are more common in degenerative. They occurs into the multiple planes associated usually in osteoarthritis changes or acromegalia changes, and more common in the older individuals. So the examination and diagnostic for this is people describe a peak clearly during the weight bearing activity. Maybe pop is heard or not depending upon the injury level. The complaint of catching or giving away. Locking is very common in case of the meniscus, which is locked into the intercondylar area. Of the patients, recall this instance where the knee was rotated or giving away, causing the tear. Same mention cause reproducible pain. So that forms the basis for the clinical tests. So the case of multiple tests is is basically the sensitivity and specificity, where the the isolated test less sensitive or specificity, but McMurray's test combined with the positive joint line tenderness or a mechanical history that can increase a sensitive specificity for diagnosis on the clinical basis. But again, the gold standard for this meniscal injury is MRI. So the management can be an operative and non-operative management. So management is basically observe or non-surgical when the meniscal injury, which is less than 1 centimeter in a stable pattern, no mechanical symptoms, either located in the periphery and patient's less active or a physical activity level is less. But when it comes to an operative, these are usually high demand, complex tears, young age patients, where the operative can vary from meniscal repair, either open on arthroscopy or meniscal allograft. So the meniscal repair will not go into the detail as Sir will be speaking this. So just to touch on the rehabilitation, there is people saying immediate wearing and the range of motions will not cause much difference in the outcome when compared to the delayed weight bearing and range of motions. So this is paper. Meniscectomy is one thing we need to know. It basically described that removing all unstable fragments that comes into the joints and causes the mechanical symptoms so as to make meniscus relatively smooth and a stable ring. So multiple portals, I think Sir has explained in the diagnostic. Meniscectomy, total meniscectomy procedure was initially used, but now it is always a partial meniscectomy because the importance of meniscus is well established, where the 50% of femoral contact area is lost after a total meniscectomy and 20% of shock absorption is lost, and the peak factor is in almost 200 to 300 times that of normal. So the partial meniscectomy was advised most of this. So suited for the patients at the inner 2/3 of the meniscus, those are unstable, causing a mechanical symptom where the vascularity is the prognostic factors being age is less than 40, minimal chondral damages, single injury or an acute injury, and risk of developing long-term arthritis or the outcome is basically in an age group more than 40 to 50 malalignment, and whether we are doing it in medial or a lateral meniscectomy. So partial meniscectomy indicated for the flap tears, cleavage tears, radial tears in the inner the margin roots is increased more than 350 times almost to the local contact area. Medial meniscectomy decreases contact area almost to 70% and increases stresses by around 100%, but lateral meniscectomy being a concave to convex area decreases the contact area by 50%, stressor increases by more than 200 to 300 times. So allograft is no experience at present, but this is one thing is harvesting from donor and process. And there is a coax meniscus there with in a very young age group where meniscus cannot be salvaged. So technique basically anterior is I think anterior to posterior tibial width is measured on lateral X-ray. It's an arthroscopy procedure performed with bone plugs. Using a bone plugs increases the stability of graft and a bone-to-bone fixation, bone-to-bone union. Once fixed, the meniscus repair techniques is routine meniscus repair. So these are indicated for the previous total or subtotal meniscectomy, compartmental pain, early osteoarthritis in relatively young age group, but they are contraindicated in varus valgus or malalignment or severe arthritis cases. So this rehabilitation, meniscal allograft, it seems like the meniscus repair where the full weight bearing doesn't changes much whether you do an early rehabilitation or a waiting in rehabilitation. So non-operative management is also important in a age group more than 50 where it is generative tests, and in a degenerative test where the patient is more than 50, medial compartment osteoarthritis, and usually these are degenerative rehabilitations. Yes, thank you. Any questions?
Thank you very much, Dr. Shrenik. and this was a wonderful talk. With the permission of everyone, I can start my lecture. Moderator, do you permit me?
Please, sir, go
Yes.
ahead.
So, can everyone hear me?
Yes, you're audible.
Yeah, and I guess my screen also is visible, right?
No,
It's not visible?
no, sir.
Just hold on. Share.
Yes,
Can you see?
visible.
Okay, great. So, just good evening, everyone. I'm Dr. Fayaz Memon. I thank Bombay Orthopedic Society to have given this opportunity to speak in this prestigious webinar on knee arthroscopy. So I'll be speaking on meniscus root tears. So as my previous speaker, Dr. Shrenik, spoke on meniscus tears, we need to know what is the importance of meniscus root tears. So biomechanically, if you see, you can see this circular fibers of the meniscus, and meniscus is attached to the bone only at its roots, anteriorly and posteriorly. So if these round fibers, if you can see, these fibers, if they are intact, and if they have to function for the function, for the reason why these have been made, the roots have to be intact. So this was identified first as early as 1948 by Dr. Fairbank in JBJS 1948. He said that if the meniscus is to take part in the weight bearing, it can only do so if there is a force which prevents it from slipping out. So like a orange pip squeezed between the fingers, you know. So if at all meniscus has to function properly, the roots have to be intact. And we cannot just say that the roots will not be intact, still the meniscus will function. And this is the cadaveric model in which we can see that the meniscus roots are there. So this is how it looks. So biomechanically, meniscus helps in load transmission. It converts the compressive forces into hoop stresses. It increases the contact area because it's the rounded structure of the femoral condyle and the flat surface of the tibia. And if this rounded structure has to have all its stresses going properly down into the tibia, these meniscal roots have to be intact. Stability wise, it helps the medial meniscus resists anterior translation and lateral meniscus resists anterolateral rotation. It also contributes to the tibial slope. So this study has shown that the meniscus root tear is similar to total meniscectomy. So here you can see that in a meniscal root, in case of a meniscal root tear and meniscectomy, the peak contact pressure is almost the same. This is another study in which they have shown that the repair of the lateral meniscus posterior horn detachment lesions give the peak pressure equivalent to the intact meniscus. So this black line and red line are almost the same in all the pressure scenarios of the gait cycle. This robotic sectional study showed that after division of the lateral meniscus root and meniscofemoral ligament, there is increase in anterior translation of the lateral compartment on the pivot shift load. Another study has shown that the repair of the lateral posterior meniscal root improves stability in an ACL deficient knee. This is another study in which it is shown that dividing the lateral meniscus root increases the internal rotation in 60 and 90 degrees of flexion angles. And if subsequently the meniscofemoral ligament is again divided or it is transected, then this will lead to increased internal rotation in all the flexion angles. So these are the importances of the meniscal root being intact. It is this another study has also shown that it has an impact on the tibial slope. So the meniscus tends to correct the slope towards horizontal. To get all these effects, the meniscus root needs to be intact. This is a wonderful study in which it has been shown how the axial compression forces can convert into the femoral external rotation in case the lateral posterior horn of the lateral meniscus, posterior root of the lateral meniscus is transected. So coming to the classification, we all know that these are classified in several types. The type 1 is partial root tear. Another one, type 2, is complete radial root tear. Then the type 3 is complete root tear along with the bucket handle meniscus tear. Type 4 is oblique tear. And type 5 is the tear along with the sliver of the bone. So if you see arthroscopically, this is the fraying root lesion, you can see here. The another one is partial root lesion. This is traumatic root lesion. This is the avulsion along with the sliver of the bone, you can see here. And this is the degenerative chronic tear. On MRI, you can see in the coronal sections here, when the section is taken little posteriorly, you can find that there is a meniscal root tear here in the coronal section. At times, if the meniscal root tear is little older, you can find that the root has left from here and the meniscus has slipped outside, and here you will find little amount of extrusion of the meniscus. This is the ghost sign. Here you should actually see in a coronal section, in a sagittal section, you should actually see the triangle of the meniscus over here, which should be black. But because here the root is torn and the meniscus is extruded, you can see here that there is no meniscus, or this is also called a ghost sign. If you are lucky enough to have exact transverse cut through the meniscus, you can also identify this kind of a lesion in case of a meniscal root tear. So the management of meniscal root tear is according to this algorithm. If the candidate is not surgical, of course, we have to go for non-operative treatment. But if the candidate is surgical, then we have to identify whether it is an acute or a chronic tear. If it is an acute tear, without thinking anything, you must go and do the meniscus root repair. But if it is a chronic tear, you have to identify whether there is a pre-existing grade 3 or 4 arthritis. If it is arthritic, then repairing a meniscal root is not going to help, because anyways, the forces those were supposed to be protected have lost its importance. And here you have to go ahead and do the partial meniscectomy so that the meniscus doesn't rip off the remaining of the cartilage. And if there is no arthritis in a chronic tear, then you should again go and repair the meniscus root. So what do we do in case of repairing the meniscus root? Here we make a tunnel through the tibia, take the stitch through the root of the meniscus, and then railroad this suture through which we have tied the meniscal root, and then tied anteriorly to the bone. So this is a small video in which we have done the meniscus root repair. So first, just clear off whatever fraying is there and identify whether you can reduce the meniscus. Then take this suture or a tape and take 2 bites with a loop kind of configuration, and then drill the bone, clear the debris, and suck out all the bony pieces or the cartilage tissue. Bare little amount of cartilage from there and bring the surface of the bone for better healing, and clear off all the cartilage. Then put in a needle and pass the nitinol wire and bring it out from the same portal where your suture is coming out from, and then railroad these sutures into the same tunnel and pull it out and tie the sutures outside with a suture disc. This is how the post-operative X-ray looks. So in conclusion, the meniscal root tears have significant biomechanical implications. Meniscal root injury increases cartilage contact pressure, Lateral meniscal root injury increases rotational instability, and the root tears may alter the functional tibial slope. We all know that the tibial slope of more than 12 degrees has got higher chances of ACL re-tear. So if you repair these roots, the chances of correcting the tibial slope to horizontal are good, and thereby our other surgery like ACL surgery or whatever we do will be better protected. I thank you very much for the kind attention.
Excellent, excellent presentation, sir.
So any questions from anyone?
Dr. Fayaz, no, Dr. Nikhil here. Just one
Yeah.
question. What is your, if you see a extrusion, often you see the extrusion of more than 3 mm, 4 mm, 5 mm. So anything take that you decide to fix this extrusion? Sometimes or you leave it alone any threshold?
So one has to understand the biomechanics as we just spoke. So if the root is torn over here and that is the cause of the extrusion, then we fix the root and the extrusion goes away. If it is an arthritic knee where the whole surfaces are destroyed, then this extrusion bringing it back is not going to help. Extrusion by itself, extrusion is not the cause of the arthritis, it is the effect of arthritis, or it is the effect of the root tear. So we need to understand that why this extrusion has occurred. If it is because of arthritis, then we need to treat the arthritis. If it is because of the root tear, we need to treat the root tear. By per se, extrusion itself is not the reason for arthritis. It is the effect of arthritis. So I have seen many people who have fixed the extrusion by bringing it medially and all. I don't think it really helps because you cannot create those fibers. The meniscus has to be attached to the bone.
Sometimes you see that the root is torn. In a chronic cases, it is retracted, like the tear may be more than 1 centimeter, around 1 centimeter, and it's not coming to its attachment.
The repair will only work.
So what is your take on that?
Yeah, so the repair of the meniscal root will only work if you can bring it back to its place. If you cannot bring it back to the place, even if you bring it back, there is going to be another tear where the stresses are high. So it has to be able to, and take it from me that unless it is an arthritic knee, it does come back to its original. If the arthritis is set in, then the whole biomechanics have changed, and then it will not be able to come back.
Thank you.
Is that good?
Excellent.
Anybody else? Yeah.
Sir, do you fix your root in flexion or extension?
You can fix it either ways because that is not the part of any of the ligaments. You can just extend it and fix it. You should see that the root is come in place and it is tight enough in all flexion and extensions. That way.
Okay.
Sir, one thing if I can ask.
Yeah.
You always tend to take this luggage sutures, sir. So many times if you try to pull the luggage suture, the posterior aspect of the meniscus slips off.
Yeah. So if that happens, that means our bites are not farther enough to prevent it. So that's why I have started using this flat thing, not the sharp edged sutures, little tape kind of stuff.
Yeah.
Second thing is, in doing this, many a times we find that the capsule is separated or from posterior aspect. So go ahead and fix that to the capsule also, so that this will reinforce the healing.
Sir, just one question.
Yeah.
So I saw you using 2 sutures for the repair. So very often that happens is when you tie down the medial suture, you notice that the lateral suture has become lax. So is there any order that you tie down these sutures because you have put cinch knots?
Yeah. I have not preferred any orders. I see to it that having tied both, sometimes I cross connect those two so that both of them are pulling them together.
So you connect one to another.
Yes.
And
personally, just as a comment, I have stopped using the cinch because I somehow noticed that not putting a cinch inside intra-articular and just pulling down the sutures itself and tying onto a button gives a closed loop and a biomechanically superior construct.
Yeah, it's
just like pull.
visualized. So there are no laws abiding this. So whatever works with an individual has to be done by person. So there are no algorithms to be followed in this. At least I don't know of.
If I
Sir,
may ask,
actually,
is
with
the
respect to the
preferred
same point, so if you have a luggage suture, it is a point contact. So you pull it, it is going to be in that particular direction. Versus if you have a suture which is exactly the similar kind of a thing, and when you pull it, the entire meniscus footprint is going to get in
It
contact
is
with the
actually easier.
the
Actually, it is easier said than done. Every time you don't find the same configuration of the tear. So depending upon what kind of a configuration, you can have that leverage here and there. You can always whatever you feel ke isse zyada behtar hoga. This could help better in this case. You can customize your techniques accordingly.
Perfect. Great. So let's move on to the next topic.
Yeah.
We have Dr. Sajir Usman. Sir, ready?
Yeah.
With PCL reconstruction.
Okay, I'm just quickly going to show only a video technique of my PCL reconstruction. Now, just as a prequel to this, my screen is visible, correct?
Yes.
Okay, so just as a prequel, we do not select all cases are by default for a reconstructive procedure like PCL. Those cases which we try to conserve and have failed conservative management are the ones that we take up for a PCL reconstruction, especially in the young to the upper middle age group individuals. The middle age and patients from the 40 plus group have a very high tendency of compensating well with a PCL deficiency. So for us, the ideal time for a PCL reconstruction would be anywhere after 2 months to 3 months post an injury, where there is significant sag in spite of a conservative trial. And most often we do see a good remnant in these cases. And this technique of PCL reconstruction, which I have presented in this video, revolves around how you can do a good remnant preserving PCL reconstruction when you plan your surgical approach. So as a standard in all these cases, we like to make a higher anterior medial portal and approach the PCL from the working portal in a slightly higher direction so that we can get the right approach angle towards that interval between the ACL and the PCL. So we call this the three windows that we can create to approach the PCL from all sides. So the first window is creating the interval between the anterior cruciate and the posterior cruciate ligament. So here, if you direct your shaver away from the ACL, it can either be towards the floor or it can be towards the PCL itself or it can be towards the roof. When you're doing it towards the roof, you often find these bleeders which can start bleeding and disturb your field altogether. So the best position to hold the shaver would be pointing down or towards the PCL, because even if you take some part of the remnants off, it's okay. But to create this interval, you have to introduce your shaver in a direction that you do not damage both the ACL and the PCL, and go and start visualizing the posterior compartment, and then you can start seeing the septum, and part of the septum, when it is dissected out, you can start seeing the entire posterior medial compartment. So once you start seeing this compartment, you are sure that now you can change and start visualizing from between the ACL, PCL and the medial femoral condyle to create your posterior medial portal. So once the posterior medial portal is created, a cannulation is necessary in these areas because it is necessary to repeatedly pass the scope and the instruments to the posterior compartment. And hence a cannula in this area will help one to repeatedly shift instrumentation between the posterior and the anterior portal. So window number one, between the anterior cruciate ligament and the posterior cruciate ligament. Window two is this visualization window, which is essentially between the PCL and the medial femoral condyle. And window three is the posterior medial portal that one has to create to do this surgery in a efficient manner. So if you start introducing your instrument from the posterior portal and do the posterior dissection, one can visualize from anterior, either from the interval between the PCL and the MFC, or between the ACL and PCL, to see how deep you are going. And at this stage, one can even shift to a 70-degree scope to get a better visualization, deeper visualization, to see how much of the posterior capsule one needs to elevate. I like to use the shaver until I have the freedom of dissection, where I feel sometimes that it is now the time to shift to a radiofrequency ablator, because typically when you go roughly around 6 to 7 mm of capsular elevation, that's when you get some bleeders, and a radiofrequency device is essential at this point to be introduced from the posterior medial portal to elevate the remaining capsule, because once it starts bleeding, then it's sometimes quite difficult to find those bleeders and occlude them. So here you can see that the posterior capsular elevation is being done to a certain level with a shaver, and the radiofrequency ablator is now introduced to elevate the remaining capsule. The position or the point where one tends to stop is when you start seeing the fibers of the popliteus muscle. Now, this can be most often seen as a dark corner. Of course, in this video, it's not fully seen, but you can see a darkness at the end of this capsule, which indicates that the muscle fibers have come into view. And since these are not highly reflective in light, you will see only a darkness there most often. So I stop typically elevating the capsule beyond this, because that's the amount of capsule that I want to elevate for placing my jig. And one other common landmark that one can observe is the medial mammillary body. So most often you may not see the lateral mammillary body, but the medial mammillary body and the shiny white fibers may be observed most often. And if one doesn't want to take off the remnant material of the PCL from the tibial side, it is not necessary to visualize both mammillary body, but at least one, so that you know that you're placing your jig lateral to the medial mammillary body. That way you ensure that your jig is central and exactly at the tibial footprint of the PCL. So once the capsular elevation is satisfactory, you can insert the jig through the anterior medial portal between the interval that you created between the ACL and the PCL. And once this placement is very clearly shown in Strobel's textbook, that's what we always follow. The Strobel's steps of a PCL reconstruction in his entire book is very nicely shown. So if you can place the jig at the tibial footprint as shown here, you can see and trace the PCL fibers itself, and one doesn't need to dissect. You can see how you can place the jig directly on the longitudinal PCL fibers, and you can see those fibers exactly here. And roughly around 16 to 18 millimeter in a medium-sized individual is what we are looking at to keep the tunnel at the tibial side exactly above the champagne drop-off. And if one does place the jig here, these kind of jig by Arthrex is very good, because it has a hole to receive the pin, and the pin can remain locked in the jig while you are reaming the tibial socket. And during the tibial tunnel preparation, the jig holds on to the pin throughout the entire process, so that it prevents migration of the pin posteriorly, which is the most common step where one tends to injure the posterior neurovascular bundle. So I like to visualize, and I also like to hold on to the pin where during the tibial tunnel preparation. This jig prevents me from creating the posterior lateral portal. In case I do not have this jig and I want to hold on to the pin while the tibial tunneling is being done, I don't mind creating an additional posterior lateral portal to introduce a device like as simple as a blunt hemostat to hold on to the wire while the tibial tunneling is completed. So once the tibial tunneling is done, the tunnel or the socket entry at the tibial site is cleared. One additional tip that we even do in addition to just using a shaver would be just using a radio frequency device and creating essentially a slot on the superior side, so that the graft can seat in this socket, and also it helps passage of the graft better if you really have a groove or a slot for the PCL on the tibial side footprint. So once the tibial socket preparation is done, you need to pass sutures. The most reliable way of passing sutures is just passing a simple ethylene suture or proline suture through the tibial tunnel and receiving it with a curved grasper from the anterior portal. But if one has difficulties doing it, you can retrieve the sutures through the posterior medial cannula and then retrieve it anteriorly, which makes it much more easier. So here the sutures are retrieved, and then the remaining portion of the surgery is all anterior. The main problem, which is the posterior medial portal preparation and the posterior tunneling work, once if it's done, there are various options. You can drill the tibial tunnel, femoral tunnel. And here we have shown how to use an outside-in jig for the femoral tunneling, but I do not prefer this now because most often my medial exit point turns out to be very much anterior and smaller. So hence I use the inside out wire drilling, freehand eyeballing, so that I can get a slightly longer tunnel in the medial femoral condyle, which prevents any anterior blowout or two proximal positions in relation to the medial femoral condyle. So essentially the steps are the same. The outside in jig is not placed. The visualization is shifted to the anterior medial portal. The wire is placed exactly at the tibial footprint, and the drilling is done from the anterior lateral portal inside out, and the wire is retrieved outside and it is placed exactly at the tip, and the reaming is done from outside in. And while the reaming is done, one additional tip is to complete the terminal few rounds by hand only, so that the remnant fibers of the PCL is not destroyed and you can retain them while you complete your femoral tunneling. So once this tunneling is completed, at this stage as well, I like to take out some fibers of the PCL over here in the superior portion, which is essentially the you are creating a slot for the graft to be sitting here, because majority of your good remnant healthy fibers are right here, and the graft will come exactly at the functional position which you need. So once the socket is prepared and the loops are passed, the biggest problem of the PCL, which everyone discusses, is the killer turn. And this is what we learned from the all inside PCL passage, graft passage, that we can use two sutures, one for the femoral socket, one for the tibial socket. And if you have two loops, and if you do an intra-articular passage of the graft, rather than passing the graft from the tibial tunnel, you pass the graft from the intra-articular portion into the tibial socket first, and then take the graft up into the femoral side. That way you are circumventing the killer turn altogether. So here two loops, you can see that both the loops are being retrieved through a virtual cannula, and the graft is being introduced into the tibial site. And now once the apex of the graft is visualized intra-articular, the loop is passed into the femoral site and the graft is passed into the femoral socket. And once the adequate amount of graft is inserted into the femoral socket, you can use different methods of fixation. Our preferred method is using a simple screw. So screw on both sides. At the end of the procedure, one can see that you can do a good remnant preserving PCL. Here one can observe the sloppy ACL sign is being negated. And we can do a good remnant preserving PCL reconstruction with this simple technique.
Can we make it little faster because we are short of time?
I'm done.
Any questions?
Only one question. The PCL graft is passed over the PCL from the interseptal rent, or is it passed from below the PCL?
Okay, you're asking whether you will pass it through above the PCL or below the
Above the
PCL.
PCL or below the PCL?
So usually I like to pass it above the PCL.
Okay.
Above the PCL, yeah, because that itself acts as acts like a support for the graft to be seated on.
Okay.
Great.
So I think it's time for the next lecture by Dr. Tejas Waghela on ramp lesions. Dr. Tejas, are you ready with your lecture?
Yes, sir. Can you see my screen?
I can see your screen, and I would request you to please abide by time.
Perfect. So, first of all, I'd like to thank everyone from Bombay Orthopedic Society for inviting me here. Okay, perfect. So thank you once again to Bombay Orthopedic Society. This is a curtain raiser for WIROC 2024. I hope I see every one of you there. My name is Tejas Waghela. I'm from Akola, Maharashtra. I'm a knee and shoulder surgeon. So I'm going to be talking quickly on ramp lesions. They were described in 1998 by Strobel, and they are basically the peripheral posterior horn medial meniscal tears. They're at the level of the meniscocapsular junction, and generally, originally when it was described, it was around 2.5 centimeters in the mediolateral axis. Now, initially they thought that they were very rare. However, now the incidence is high as 40%, and it's more common with chronic insufficiencies. That means all of us are seeing them. So they are basically what? You can see this beautiful lady here with a peel. There's another beautiful lady who's peeling it back. So let's look at what happens with the ramp. So what exactly happens with the ramp is when you view from the posterior side, the posteromedial or the meniscotibial ligament, which is attached, it peels back and goes down from the superior to the inferior portion like a ramp. And that's how the ramp has a slope, and that's why this is called a ramp lesion. So what does exactly peel? Now, Hogeshala has a lot of extensive and very nice cadaveric demonstrations. And you can see that what exactly peels is the meniscocapsular ligament and part of the meniscotibial ligament. The meniscotibial ligament is attached, as you can see in these pictures, on the center of the meniscus, which makes it stable, and it is attached around 6 millimeters distal onto the tibia. There's also significant attachments on from the medial femoral condyle to the posterior oblique ligament and the deep MCL. However, the most important part for us to concern when the ramps are being described is the posterior third, which includes predominantly the meniscotibial and the meniscocapsular attachments. There is also a dynamic sling which is attached from the semimembranosus, which goes and attaches towards the posterior half along with part of the meniscotibial attachment. And all these, when they are pulled, can lead to a peel back of the posterior capsule and the structures, and hence called a ramp. So as you can see here, that's the area where your ramp should be. If you have a pull which is anteroposterior, if you have a pull which is rotatory, predominantly the semimembranosus taking the tibia into internal rotation, or you have a significant valgus stress which rips off the POL, the deep MCL, and the posterior medial capsule, this will lead to medial and rotatory instability and probably ramps. So that's what we have been discussing. Arthroscopically, that's how they look. Now the peel can tear in different parts. It can tear singly, it can tear multiply. And that's how you have the different types of ramp. The different types of ramp, as described by Thornau, is the commonest one which is used in practice. And these are divided into 5 types. You all can go through this in literature and I won't waste your time with it. However, something which is really interesting is that partial superior tears, which are type 2 tears, have a thin covering over them and might be overlooked when you go into the posterior side and do your posterior diagnostic arthroscopy, as very well described by one of the previous speakers. Why do you repair them? A lot of times they say that you need not be repairing them. Small stable tears don't require repair. There's a very interesting biomechanical study from Laprade and Hogeshala group, where they have said that there is increased anterior tibial translation, especially in ACL deficient knees. There's increased tibial internal and external rotation at all angles. And when you reconstruct only the ACL, you might be able to restore the anterior tibial translation. However, the pivot shift and the rotatory instability might persist. What this theoretical study tells us is that in our chronic ACL deficient patients, if we miss a big ramp, I'm not talking of smaller ramps, I'm talking of big ramps, then there's high likelihood that in the long run, these patients can definitely fail. So how can you pick them up before you go for surgery? Now we have to remember that MRIs are done in full extension. And as I said, it is a peel back. So whenever it is peeling back, you need a force which is in flexion. And unfortunately, not all our MRIs done in flexion. So it's very tough to diagnose these. However, there are these subtle signs which you can pick up. One is a thin fluid signal, your standard longitudinal oblique tears which you see in the meniscus. And of course, there can be a countercoup brew because of a pivot shift injury. So how do I make it? I see to it that if I see a patient who has an explosive pivot, something like this, then there are two things which come to my mind. One, either there's a root tear or there's a ramp tear. The third way to diagnose it is the way the Lyon French group have described it, which is using a spinal needle or an 18-gauge needle in the posterior medial side. One takeaway from this small talk would be that whenever you do chronic ACL insufficiency, go into the posterior compartment, identify the folds, pass a needle, and try to probe. And especially type 2 lesions, which have a thin layer covering on them, you will be able to peel it off and find that there's a large tear and an exposed posterior tibial plateau. And these you might have to fix. So what are the fundamental skills that you need to master when you're doing a ramp repair? Well, first, you need to know how to do a posterior compartmental arthroscopy. Well, all of us know it by the looks of it. However, someone who is seeing this for the first time, you can try flexion, internal rotation, a bit of valgus stress, and gentle maneuvering. If that doesn't work, you can remove a bit of synovium over the PCL. If that doesn't work, you can pass a blunt trocar, even a blunt K-wire can help you in doing that. You should have some basic shoulder skills. Suture shuttling techniques, knot tying. One thing about knot tying, I feel that you should try and use non-sliding knots when you're doing your ramp repairs, because sliding knots can give you more pressure and sometimes they can rip off, especially when you're trying to do an acute ramp. And of course, the workhorse for all of us, for all our meniscal repairs should be inside-out meniscal repairs. And last but not the least, develop a team who can see to it that you do your ACL reconstruction faster. If you do your ACL reconstruction faster, you'll be able to find all the other things and try to repair them. Otherwise, you'll be stuck and anxious about your basic surgery. How I do it through a single portal. I use a suture passer. There are certain specially angulated passers. However, for me, 45 degrees has worked so far. We pass the suture around the tear. I have used Ethibond number 2, which is controversial, but I have been using it for a long time. Slowly, we are shifting, and we have now started even using number 2 fiber wire. Of course, inside-out repair, we all know, and this is not the scope of my talk, so I just have one slide in it, that when you try to do this inside-out, try to identify the interval, as shown in the second diagram, between the medial gastrocnemius, the semimembranosus, and the POL. And I use a standard kitchen spoon, as you can see in the picture there, and pass all my sutures in flexion. I first pierce the needle in 20 degrees, flex the knee at 90 degrees, pass the sutures, tie them with a hemostat, keep them segregated, tie them under vision so that I don't over-constrain it, and finish the job. How about all inside devices? Not a big fan of all inside devices for ramp repair. Why? Because I find the capsule to be very patulous. I find it to be very thin. And these are very thick. They can rip off. I have ripped it. I have wasted fast fix. I've wasted all inside devices. So I would recommend to do it in the standard shoulder way in which we do it, which is passing it through the shuttle. So to conclude, ramp tears are more common than previously thought. Untreated ramps may lead to increased AP, rotational torque on the knee, as well as your grafts, and might ultimately lead to failure of the ACLs. When you try to look for these, especially in chronic situations, your patient is having an explosive pivot shift, then see to it whether the root or the ramp is ripped. Always palpate the meniscus, as very well pointed out during the meniscal tear talk, and looks for the excursion. And posterior diagnostic arthroscopy should be done in all chronic ACL surgeries. Thank you.
Thank you very much, Tejas, for an excellent talk. Because of the scarcity of the time, I think we'll straight away go to the next lecture by Dr. Rohan Bidwai, all the way from UK. He's taken out
Thank you.
for this lecture on decision-making in patellofemoral instability. Over to you, Dr. Rohan. Somehow we can't hear your voice. Can you unmute yourself, Rohan?
Hi, sir. Thank you, Faya, sir. Thank you very much for inviting me. Thank you to the BOS. It is wonderful to meet all my teachers and my colleagues here. So I'll be having a brief talk. I'm aware that I'm the last one for the evening. I'll try to keep it as brief as possible. I'll try to shed some light on decision-making in patellofemoral instability while working at this unit, which is like a tertiary unit for the patellofemoral issues. Can see my slide? Yeah. So what is it? We are aware that it's a common cause of disability in young patients. The classic patient is a young female where the incidence can go up to 29 in 1 lakh population. It is an enigma, and we are aware that every 6 months there is new evidence coming up with patellofemoral instability. So we are aware that the tracking is essentially of two things: osseous constraints and the soft tissue structures. In the osseous constraint, the patella, once it goes beyond the 30 degree of flexion, the bony morphology will take care of the stability, unless there are other components like the patella alta or other bony abnormalities. What is more important in the soft tissue stabilizers are the dynamic and the static one. The dynamic one, the VMO and the IT band play a pivotal role in during the motion where they maintain the patella inline tracking. About the static stabilizers, the most important is the MPFL. There are other components to it with the MPTL, MPML, and there is more evidence coming to the relevance of this in medial stabilizers of patella. Mechanisms, it will help in deciding what treatment plan is to be guided. The 5 important things are to look for trochlear dysplasia, patella alta, increased TTTG distance, and if there's a torsional malalignment. When it comes to decision making, we'll start with a classic history. Few important questions to be asked in history of what is the first episode of the dislocation. Was it a traumatic or a atraumatic? Atraumatic dislocation would raise concern about is there an anatomical predisposing factor. What was the method of reduction? Because that will increase the chance of having an osteochondral injury. If it's a recurrent instability, how long this has been going on and how frequent, because that would then lead to osteochondral lesion, which would affect your surgical decision making when it comes to patellofemoral instability. A presence of hemarthrosis, again, raises the possibility of an urgent MRI, which can help in osteochondral injuries. And mechanism, many times patients say to us, every time the patella dislocates, every time you go beyond 20 degree of flexion, which again highlights the importance of this history in the decision making. Examination wise, apart from your Byton score, the coronal alignment, gait examination is very pivotal. A classic finding is when the patella is pointing inwards, or what is called as squinting patelli. It raises the concern of there is an underlying femoral anteversion or patibia extortion, which can again be helpful in deciding whether you need a derotation osteotomy for managing the patellofemoral instability. In sitting position, a J sign can be indicative of trochlear dysplasia. Either you do a J sign or a reverse J sign, which depends on you going from flexion to extension or extension to flexion. Patella tilt, the mobility of patella, and the passive patella apprehension, all are important in establishing the medial integrity of the structures. Prone examination, again, the version. So the first clinical suspicion, whether your treatment plan in a young patient with a recurrent instability with atraumatic would be how is the patient behaving in a prone position, and what is the version like? So is there any difference between the internal and external rotation of the hip? in the prone position, which can give a suspicion of whether it is a significantly anteverted femur or a tibial torsion on thigh foot progression angle. This examination points by itself would not help in decision making, but yeah, it can help in a role of CT scan of what this could help in further surgical management. A 30-degree flexion lateral knee X-ray is the most important investigation. It can show your patellar height, the crossing sign, the presence of a spur, and which comes in a different parts of a Dijon dysplasia. CT scan, once there is a suspicion that the patient's having had increased anteversion or in the gait examination, you can have 3 parameters. There is ongoing research going on the exact parameters of what are the cutoff to say, oh, these are more than what it is normal, what is the cutoff from surgery. And there is need to have more race-specific parameters. The guidelines followed here are the femoral anteversion of 15-degree, the knee joint rotation of 8-degree, and tibial torsion of 23-degree. Obviously, you would not consider a surgery immediately when the value shoot over it, but a value double than what the femoral anteversion is a good indication of dealing with the problem. MRI, the standard of care in the acute scenario, can help in delineating the osteochondral injuries, while in the chronic scenario, it can help in your trochlear morphology, the patellar trochlear index, and the Caton Deschamps index, which is useful for, again, delineating the surgery. A few slides on trochlear dysplasia. In the simplest of the term, the type A is a shallow trochlea where it generally retains the shape. Type B is a one which is slightly convex and one of the indications for doing a trochleoplasty. A type C is again, there is double contouring where there are 2 separate ridges and a groove is asymmetrical, but most of the time you can get away in a type C trochlear dysplasia by addressing the other factors of patella alta or medializing the groove, medializing the tracking or doing MPFL. Type D is the one where it's a barn door case for doing a trochleoplasty because of significant trochlear bump, and they are the patients who benefit a lot from sulcus deepening trochleoplasty. So when I see a patient with acute instability, most of the time, if there is no presence of loose body or osteochondral lesion, which is established obviously in an MRI, there can be for non-surgical treatment. So the goals are to look and treat osteochondral lesion when you first encounter them, stabilize the patella, improve the tracking, and prevent or treat arthritis. So who are the patients who I can conserve for non-operative treatment? The ESCA has come up with a comprehensive guideline of managing a first-time patella dislocation. So a first-time dislocator with a no predisposing factor, no chondral osteochondral lesion can be conserved, where the goal should be to focus on the closed chain and open chain quadriceps and hip abduct exercises, and also the core strengthening, which can be the answer for the patella instability. There is recent evidence where they have shown the reduced redislocation rate and improved patient outcomes for a first-time dislocator, but that can be a very personalized approach in a patient with a known predisposing factor. It's a recurrent instability. The management would be guided by the presenting predisposing factor. It's a busy slide. We'll go individually in this. MPFL, it's a versatile procedure. However, it has a limit. There is a very limited role of isolated MPFL if other factors are not considered, the patellar tendon height, the trochlear morphology. Because the reconstructed MPFL is much more stronger than your native MPFL, one can get away if the other bony abnormalities are not significant. However, this can fail early, and there is the importance of having this patient continue under the follow-up. Tibial tuberosity, distalization, anteromedialization, a very powerful tool. Again, in the increased patellar height and lateralized patella. Presence of a Caton Deschamps more than 1.5 or a TTTG more than 20. Fulkerson is the choice of the osteotomy, which will distalize and anteromedialize and help the tracking in this. It cannot offshoot the scarcity of the medial structure. So most of the time, this osteotomy in an instability scenario is combined with the MPFL surgery. A sulcus deepening trochleoplasty, the classic indication is a type D or a type B trochlear dysplasia. The different techniques described. One is a thin osteochondral flaps, the barreter technique, in which you go on lifting the thin osteochondral flap, use a burr to remove the subchondral bone, and use a simple vicryl tape to put down the osteochondral flap. The long-term follow-up, there is evidence to show that in long run, it reduces the chance of arthritis apart from increasing the stability. The caveat is there should not be arthritis set in, which can make the outcome worse and patient can have significant anterior knee pain following the procedure. Derotation osteotomy, there is a lot of new evidence coming of the demonstrating more role of it. Clinical suspicion is of paramount important. However, there is again evidence to show that clinical parameters by itself would not be sufficient to see all the patient who have got excessive anteversion and excessive tibial torsion, because the way the patient compensate in gait mechanism. So in a clinical suspicion in a primary dislocator and in a revision scenario, if a patient had a previous procedure, a CT scan rotational profile will be of paramount importance. 3 parameters to check: the femoral anteversion, the knee joint rotation angle, and the tibial torsion. Again, what to correct? People correct femur derotation where there is excessive anteversion. Where would you correct it? You can correct it at the level of distal femur or proximal femur. Simple answer would be, if the patient has come to you with a problem with the knee, it is worthwhile dealing it at the level of knee. Similar to the tibial derotation osteotomy, you could either do at the level of supratubercle or at the level of infratubercle. What is practice here is at the level of tubercle, because it will help in addressing the patella downwards, which is a coexisting pathology. There is more research ongoing with regard this procedure. About the long-term data is still lacking, but it's a powerful tool again to address this particular problem. So just to summarize, patellar instability, a triple evaluation, clinical examination, history and investigation. Look for all anatomical factor and patient factors. There is increased incidence of mental health issues in this particular cohort. So a post-op physiotherapy, which is very important, can mar or make the outcome good. A la carte menu is what has been suggested by the Dijor group, and a follow-up in the longer run. So that's it really. Thank you. I would also take the opportunity to invite you to the Birmingham Patellofemoral Masterclass. It is a 2-day of pure patellofemoral course wherein the faculty from the UK and all over the world, it's 2 days of purely patellofemoral work. It's a hybrid conference, so it would be wonderful if you can make it here, or there is an online link to it as well. Thank you.
Thank you very much, everyone, all the speakers. And on behalf of Bombay Orthopedic Society, I thank one and all, Dr. Sajir, Dr. Ankit, Dr. Tejas, Dr. Rohan, Dr. Nilesh, Dr. Nikhil, Dr. Shrenik, Dr. Sandeep Biraris, all of you for having attended this and stayed back full 2 hours. In fact, it was decided to have
one moment. Dr. Sajir, can you put on your Dr. Nikhil, sir, can you just put on your camera? I know he's driving the car. But
yeah, if you can just take the screenshot and post it on the...
Yeah, wait, I'm going to do that, sir.
As usual, our friend Ankit is very good at making relations. And
wait, I don't know how to take a screenshot. That's the only problem.
Function print screen.
Thank you.
Command Shift and 5. If it's an Apple one,
it's an iPad. I'm sorry,
yeah,
I'm just
Command Shift 5.
No.